I describe it to patients usually is try to get them to picture their scapula as a big triangle, right? One on each side. So the bottom point of that triangle, I'll show them, it's right here, right? You're trying to tuck that into your back pocket, okay? And so we provide the Brugger's exercise, right? So we're just externally rotating. You'll notice the more he externally rotates, if you do it actively, so the more it will start to facilitate that locked back and down position, right? So this is the position I'll put them in to tape them for scapular facilitation. Just use 2 strips. I'll start kind of from the top of the acromion, maybe even a little bit in front. Okay, I want to avoid the big meaty part of the upper trap, right? Because I don't really want anything stimulating anything up here. I don't want that upper trap activated at all. I want it deactivated as much as possible. I want the mid and lower traps activated. Okay, so they're kind of opposing muscle actions, so we don't want to do anything here because we want this to be really done well. So I come on the more bony part to start, avoiding the big muscle belly. And then I'll come and kind of snake it down the spine of the scapula and around the medial border to come blend in at the angle of the lower traps, right? Yeah, you should be holding that set scapular position that I've already taught you during our rehab session.
Is there a lot of tension on that, or?
About 50 or so percent. I mean, depending. Sometimes if it's an athlete going into competition and I want to lock it a little bit better, I'll do like 75 or a little bit more tension, right? But for a typical just patient visit, usually 50 is good because you're going more for longevity as opposed to a specific athletic event time frame. Then we'll do another one starting from the same spot. And this time I'll come down the lateral border off the inferior angle and blend it in with the other one. K-tape is heat activated, right? So when you rub it like that, it kind of activates the adhesive and makes it stick a little bit better. And then we'll have them relax there. That's usually pretty good. For a patient, for sure, that's usually all I do. Sometimes I'll put one across for the rhomboids, right? If I need a little bit more retraction. But usually the depression is what you're after. Does that feel okay?
Yeah, feels good. I definitely feel it. Just providing that little bit of cue and support.
So that's all you want. You don't want too much, right? Because then you're going to start to overdo it, and now you're at the extreme the other way, right? It's so weird if I guess. Right? So if he's extreme one way, the body doesn't like extremes, right? So you don't want to like lock it down like a freaking cast, because then we're just extreme the other way, right? We want to be nice and neutral in the middle. Just give this a little bit of extra stimulation so that it's activated more than it is. That'll start to reciprocally inhibit some of this anterior musculature, right? Like scalenes, pec minor, that are constantly pulling everything forward, right? And upper traps, right? So we're just going to help stimulate this a little bit, relax this stuff a little bit, and you'll have a better overall scapular position throughout the day, right? And it's going to just help to retrain. In addition to all the normal things we tell somebody when we put on tape, right? Because we're always going to say, you know, if you have a bad reaction to it or it hurts or feels weird for any reason, make sure you go ahead and tear it off. Otherwise, leave it on as long as it stays. Typically, anywhere from 2 up to 5 days, right? But for this one, I also make sure I tell them that this is probably, or there's a chance that it may actually make you sore, like muscular sore, like a workout kind of, right? Because it's activating muscle groups at a very increased rate compared to what they normally are doing, right? So a lot of people actually feel they get sore back here, right? Like in the mid traps and lower traps and rhomboids. Sometimes they'll actually feel DOMS, like delayed onset muscle soreness, like a day or two from now, right? So if it gets to be too much or too sore or whatever, or starts aggravating, tear it off, right? The only other one I'll do here sometimes, you can see obviously the depression is what I'm after, right? Not so much the retraction, okay? It's the downward motion that's going to be most beneficial. A lot of people, I feel like, make the mistake sometimes of, like, you're trying to tell people to pull their shoulders back. A lot of people will